Hello and welcome. If you're new to the ICU, one of the most complex things you'll encounter is caring for a post cardiac arrest patient undergoing therapeutic temperature management or TTM. It can seem really intimidating with all the equipment and protocols. But today, we're going to break it all down. Our goal is to make you feel confident and prepared when you take on this assignment. Let's get started. So, first things first, why are we doing this? The primary goal is to protect the brain. After the heart is restarted, the brain is incredibly vulnerable. The return of blood flow, which you'd think is a good thing, actually triggers a massive inflammatory storm and swelling inside the closed box of the skull. This is called reperfusion injury. By cooling the patient, we are essentially putting their brain into a temporary hibernation. This dramatically lowers the brain's need for oxygen and gives it a chance to rest, heal, and avoid that secondary wave of damage. Remember this, TTM isn't about the heart. It's all about saving the brain. The entire TTM process is a journey with three distinct phases, and your job is to guide the patient safely through each one. Phase 1 is induction, where our goal is to cool the patient down to our target temperature, usually between 33 and 36 degrees Celsius, as quickly as we can. Phase 2 is maintenance, where we hold them at that target temperature for at least 24 hours. This is where most of your intensive monitoring will happen. Finally, we have Phase 3, rewarming. This is a very high-risk phase where we slowly bring the patient back to a normal temperature. During that 24-hour maintenance phase, your bedside skills are critical. Here's what you need to be watching. First, the heart monitor. A slow heart rate or bradycardia is expected. Don't be alarmed by a stable rhythm in the 40s. It's a normal response to being cold. Next, you'll be watching labs very closely. Cooling causes electrolytes like potassium, magnesium, and phosphorus to shift out of the blood and into the cells, so the lab values will drop. Be prepared to hang a lot of IV electrolyte replacements. You'll also see high blood sugar because the body becomes resistant to insulin when it's cold. This means you'll be doing frequent glucose checks and likely managing an insulin drip. And finally, protect the skin. These patients are extremely high risk for pressure injuries, so turning them every 2 hours is absolutely essential. I cannot stress this enough. Rewarming is a dangerous time. We have to go slow, usually no faster than a quarter of a degree Celsius per hour. Going too fast can cause two major problems. First, severe hypotension. As the body warms up, all the blood vessels that were clamped down suddenly open up, causing the blood pressure to plummet. You need to watch the BP like a hawk and anticipate the need for vasopressors. Second is rebound hyperkalemia. Remember all that potassium that moved into the cells? During rewarming, it all rushes back out into the bloodstream, which can cause fatal heart rhythms. This is why we always stop all potassium infusions before we begin to rewarm. Now let's talk about your biggest challenge at the bedside, shivering. Shivering is the body's natural attempt to warm itself up, and it is the absolute enemy of TTM. Why? Because it's like making your critically ill patient run a marathon. It skyrockets their oxygen consumption and metabolic rate, putting incredible stress on the brain and heart, the very organs we are trying to protect. Your job is to catch shivering early. Don't wait for visible, whole body shaking. Look for subtle signs like jaw clenching or tremors over the chest muscles. We manage it in a stepwise approach. Step 1 is always counterwarming. This is a neat trick where we apply a forced air warmer, like a bear hugger, to the patient's skin. This warms the skin's temperature receptors and tricks the brain into thinking the body is warm, even while the cooling device keeps the core temperature low. If that's not enough, we move to Step 2, optimizing sedation and pain control. Step 3 involves giving scheduled meds like Tylenol or IV magnesium. And only as a last resort, if nothing else works, will we move to Step 4, which is using a paralytic. This can feel like a lot to remember, so here's a simple mental checklist you can run through during your shift. Is my temperature probe reading correctly? Have I checked the latest labs and replaced electrolytes? When was the last blood sugar check? Have I done a full shivering assessment? When was the last turn? And is my patient comfortable and adequately sedated? This will help you stay on track. Let's run through some common scenarios. If you see the patient start to shiver, your first action should be to apply a counter-warming blanket. If you see a potassium of 3.00 during the maintenance phase, your first thought should be, this is expected, and you should prepare to give potassium. If the BP plummets during rewarming, think vasodilation and anticipate needing pressors. And if the potassium spikes during rewarming, think rebound hyperkalemia. Stop all potassium and notify the provider immediately. So, to summarize, during the cooling and maintenance phases, your focus is on holding that target temp, aggressively managing shivering with counterwarming first, replacing electrolytes as they drop, controlling blood sugar, and protecting the skin. And during the rewarming phase, your focus completely shifts. Now, you are ensuring the rewarming rate is slow, anticipating and treating hypotension, and watching the monitor like a hawk for any signs of hyperkalemia. Taking care of a TTM patient is a huge responsibility, but you can absolutely do it. It's built on the core ICU skills you are already learning: close monitoring, anticipating problems, and working with your team. Never, ever be afraid to ask questions. Your preceptor, your charge nurse, and your teammates are there to support you. You've got this. Thank you for your attention. I hope this helped make TTM feel more manageable. Now, I'd like to open it up for any questions you might have.